get started. I think everybody knows our forever student, Davide Cina. He's been in the program 7, 8 years now.
Hi, guys.
And he'll be talking to us about Costimulation Blockade and let us know why kidney transplants don't last longer than they should after 40 years of experience.
Sweet. All right. Hey, everyone. As Dr. Guan said, I'm Davide. I'm one of the PGY5s plus. I'm going to talk about co-stimulation blockade in renal transplant. And it's a pretty niche topic in transplant. So I recognize why some people might kind of shrug their shoulders a little bit, but I think it's important for a couple of reasons. It's important to me personally because a lot of the work I'm going to show you today and was done down at Emory, where I'm going to do my fellowship. And that's kind of the crucible of co-stimulation blockade in renal transplant. So, for me personally, it's kind of important to learn about this because clinically it's used down there a lot. The other reason I think it's important is because regardless of what direction you think transplant's going in, whether you think the next big thing is going to be xeno, or you think the next big thing is going to be tolerance or precision medicine or whatever, co-stimulation blockade is going to play a part in that. So I think as we look to the future of transplantation, having facility with kind of understanding the clinical application of co-stimulation blockade is going to be important. Now, I like to start all of my transplant talks by talking a little bit about kind of the timeline of the development of immunosuppression in transplant. And the reason I like to highlight this is because I think a lot of great advancements happened in transplant early on out of necessity because grafts were failing. And after that, we've kind of rested on our laurels. From the first transplant that happened in twins at Brigham and Women's Hospital with Joseph Murray in 1954 that won him the Nobel Prize, into the development of the first immunosuppression regimen in 1963 that allowed for HLA disparate renal transplants with azathioprine and prednisone. We waited a little while. And then after that, the next big leap forward was the development of calcineurin inhibitors that I'm going to really talk a lot about today. Both cyclosporin and tacrolimus. Those happened in the early 80s for cyclosporin and then in the late 80s, early 90s for tacrolimus. So we waited about 20 years for that. Then we waited another 20 years before the development of any new immunosuppression. And tacrolimus and calcineurin inhibitors are still the cornerstone of our transplant treatment today. So we're still using stuff that was developed 40 years ago, and that's our standard of care. Progress has been slow in this space. And I think that we need to start thinking about how to make things better. And the reason we need to do that, and I have some objectives up here, but really the story I want to tell in the talk today is that calcineurin inhibitors, calcineurin inhibitors, while they've been seminal to the development of transplant as a field, as we've improved graft survival by just providing better care, we're starting to see the dark face of calcineurin inhibitors that are hampering long-term graft survival. And because of that, we need to think about new ways to deliver immunosuppression that don't impair graft life. And I'm going to talk a little bit about belatacept, which is kind of the most recent big development in transplant immunosuppression. Talk about a couple other co-stimulatory pathways that can be clinically blocked, and then kind of offer up some thoughts at the end. Now, I like to talk a little bit about kind of framing the problem before we get into the actual nature of the immunosuppressions that I'm going to talk about today. And I always like to think a little bit about end-stage renal disease as a problem. And I do want to point out that this is a rising problem in the modern world. The prevalence of patients on dialysis in Canada, and this is Canadian data from the CIHI database, is increasing year after year. And that's the graph with the kind of green hashed lines. And the prevalence of people being transplanted is not rising to meet that demand. So we have more people on dialysis, and dialysis is expensive. It costs $350,000+ a year over 5 years, with a lot of that cost being shouldered up front. So it's a prevalent and it's an expensive problem. I also like to frame dialysis and end-stage renal disease in the context of kind of other diseases we think about, because, it's easy to say, well, people's kidneys fail, we put them on dialysis, and, they get treatment, and that's fine. But the reality is that survival on dialysis is abysmal. It's really abysmal. And it's worse than some cancers that we find are concerning. And so we do quote people a 5-year mortality of about 50% for all comers on dialysis. And if you look at the actual actuarial data for this, it's not actually all that wrong. We're not exaggerating to scare people. Now, if dialysis is inadequate, what's the solution? And the obvious solution is transplant. Now, predicting the survival benefit of patients on dialysis after they receive a renal transplant is actually really challenging. But this really elegant paper by Wolf, it's kind of like a seminal paper in transplantation, tried to do this. And they looked at kind of all transplants in the US between 1991 and 1997. And this is obviously a different era of transplant. And then they said, well, we're going to just take the people who are listed for transplant. That's 46,164 patients. And because those patients who are listed for transplant are probably healthier and better, in better state of health than other dialysis patients. And then they compared those to those who actually did get a transplant, the 23,000 people who did get a transplant. And what they showed is that while early on after transplant, there's increased risk of death, that risk of death equilibrates around 106 days. And then by about 244 days, you've already made up for the increased risk of perioperative mortality, and you start accruing survival benefit. And when you do the math on that, transplant increases projected life years by about 10 years. Now, that number might be changing a bit as our dialysis care improves, but the reality is, in all of medicine, there's very few things we can do for patients that increase patients' life by about 10 years. Yeah.
Just the risk reduction like this, right? And we put into our local context here. I walk by the dialysis unit here, and those patients don't look like they're going to get 10 years with transplant. So you've got this pool of patients that are getting dialysis through limited self-care facilities out in the community that are probably, are those going to be these patients that are going to get 10 years?
Well, so the reality is the patients that you're seeing as you're walking by the dialysis unit that you're kind of real worried about, those are people who aren't even going to get a transplant probably. But if you do, but in this study, this is all comers. So even the most catastrophic patient who gets a transplant, when you look at the math over 10 years and you look at all comers, yeah, there's variability. There's, like any kind of, like any clinical trial, you're going to have people who do well and people who don't do well. But if you average all of that out, it's about 10 years. And so that means that there are people who are getting 20, 30, I think the pediatric transplant. And this study actually risk stratifies patients. So it looks at older patients and younger patients. I've not included that data for brevity because this isn't the center of my talk. But yeah, like if you take all comers, it's about 10 years, which is crazy for people who do get a transplant. And these tend to be healthier than the people who aren't even eligible for transplantation. So the solution to renal failure is transplant. And the question is, are we winning? And the answer is probably not. And this is actually really recent data, 2022, looking at all the patients who were transplanted in Canada last year, and that's 1,673. We have over 3,000 people, so almost double that, waiting for transplant. And then you have people dying on the wait list. So the question is, how do you increase the number of transplants in Canada? How do we increase the number of people who have a transplant? Certainly you can increase the number of incident transplants, which, that's a bit of a fixed pool. We only have so many organs that we can allocate that because those organs are provided by living donors and deceased donors, and those are pretty fixed numbers. And we can increase those numbers by being more aggressive in utilizing kidneys from donors after cardiac death. We've got the MAID program now, which has been a great source of organs for patients. But that number isn't going to change a ton. What you can do, however, is do work to decrease the risk of graft loss. And really, that's going to be the focus of my talk today, really, is what can we do with immunosuppression to reduce the risk of graft loss in the long term? We have been doing a good job as a society as a whole, as transplant providers, in improving graft survival, so decreasing the risk of graft loss. And this is a population-based study using US data. And what they showed is that whether you're receiving a living donor kidney, a deceased donor kidney, that patient and graft survival over the last 30 years has actually improved dramatically. And so the bottom line is 1996 to 1999, and the top line is 2012 to 2015. And we can see that the curves are flattening out considerably. And the reason this is probably multifactorial. Better patient education and optimization, immune matching, immunosuppressive protocols have improved, non-invasive monitoring with deceased donor cell-free DNA, management of rejection is better, management of infectious complications and cancer is better. So our patients are living longer with grafts. But if you take a close look at the data, and this is again Canadian data from the CIHI database, what you see is that we're doing great till about 5 years. And then after 5 years, between 5 and 10 years, graft survival drops off. So the question is, why are grafts that are so successful in the first 5 years failing disproportionately later on? And this is, again, likely multifactorial, but I'm going to make the argument today that in some patients, the immunosuppression we rely on to prevent early rejection results in late graft loss and morbidity. So before I jump into talking about why I think calcineurin inhibitors might be contributing to this problem, I'm going to give a little refresher on some of the basics of transplant immunology to frame the rest of the talk. Now, a lot of the immunosuppression we rely on blocks T cell activation. And T cell allorecognition, so recognition of the graft, really takes place in 3 steps. So there's first signal is the engagement of a T cell receptor on a recipient T cell with a cognate major histocompatibility complex, or HLA, on an antigen presenting cell or on a donor cell. And that is just recognition. That's the first contact. Once that happens and it says, all right, I recognize you, we have the accelerator signal. That's the co-stimulation. And there's a number of molecules here that play a role in co-stimulation. The cancer folks will think of this as checkpoints. And the most potent of which is the engagement of CD28 on the T cell with CD80 or CD86 on the antigen presenting cell. So that's the accelerator. The last signal is like the parking brake. It's once the T cell is activated, co-stimulation has occurred, you get transcription of a proliferative signal, and production of cytokines like IL-2, which is the most potent mitogen for T cells. And that's like removing the parking brake and the T cells proliferate. Now we have a number of immunosuppressions available to us today as current standard of care, and they hit all 3 of these signals. So first, we have obviously the calcineurin inhibitors, which block signal 1. Calcineurin inhibitors bind signaling partners in the cytoplasm and block the action of calcineurin, which is required for phosphorylation of NFAT, which is a transcription factor that is like a master regulator of T cell proliferation. On the co-stimulation side, we have belatacept, which is a CTLA-4 immunoglobulin, that what it does is it blocks the engagement of CD28 with CD80 and CD86, which is kind of like an accelerator on this pathway to NFAT phosphorylation. And in the last signal, we've got a number of different agents. We've got basiliximab, which is an induction, is a monoclonal antibody against IL-2 receptor. We use it in induction. We have sirolimus and everolimus that block mTOR, which is a central growth factor signaling regulator that allows for cell proliferation. And then we've got mycophenolate and azathioprine that block purine synthesis and cell cycle progression. When you take this all into account, our current standard of immunosuppression involves 2 phases: induction, which is for preventing acute allograft rejection at the time of transplant. And this can involve either basiliximab, the monoclonal antibody against the IL-2 receptor, with methylpred, or ATG, which is a polyclonal antibody against an assortment of T cell antigens, and methylpred. The next phase is maintenance, which is to prevent cell-mediated and humoral rejection of the graft in the long term. And that involves steroids. You can either have daily steroids, or you can have a rapid steroid taper and steroid elimination. Steroids have a lot of side effects, so if you can, it's great to get rid of the steroids. An antimetabolite, nowadays it's usually mycophenolate, and a calcineurin inhibitor, either tacrolimus or cyclosporin. And this is what's so-called triple immunosuppression. I haven't included any numbers here because the exact regimen and dosing is variable based on the patient's immune risk and a patient center's experience, and every center does it a little bit different, but this is kind of the basics. And so, as I said, I'm going to really focus on this last class of medication here, the calcineurin inhibitors, because while they're very effective, I think that they've been causing harm. And so the next part of my talk is this idea that calcineurin inhibitors were a great boon to transplant. They had a lot of promise, but there's a number of pitfalls that we're starting to see now that a number of patients have been on tacrolimus for a long time. So the first calcineurin inhibitor that was discovered was cyclosporin A. It came from a fungus, and it was approved for renal transplant in 1983. And I had to dig way back into the archives for this one. And this is a retrospective study. This chart you see on the right is from a retrospective study in the New England Journal of Medicine in 1984. And this is back when you could get a retrospective study into the New England Journal with less than 100 patients. But what they show is that the use of cyclosporin A relative to azathioprine and steroids, which was the prior standard, actually improved one-year graft survival by about 20%. So from 60%, so you imagine 60% one-year graft survival, which is abysmal, to 80%, which is still not our standard for today, but it's a lot better. After cyclosporin came along, tacrolimus was the next calcineurin inhibitor developed. Again, it also came from a fungus. And it was first used in 1989 by Starzl and colleagues, and he thought that the data was so convincing that you didn't need a trial. A lot of people disagreed with him. That was kind of his personality. So it actually didn't get approved until 1999 for use in transplant, but it was used before that. And tacrolimus has really taken over. Almost every center primarily uses tacrolimus, unless they have a good reason to use cyclosporin. And the reason they have is because tacrolimus does perform better. And I think that this randomized control trial really this Cochrane review of randomized control trials summarizes this nicely. And it shows 30 RCTs, including over 4,000 patients, and tacrolimus performs better for rejection at death-censored graft loss at 6 months and at 3 years. Tacrolimus, however, does have a bit of a dark side, and it does worse than cyclosporin for de novo diabetes at 3 years and for neurologic symptoms. Cyclosporin performs worse for dyslipidemia, but we have to keep in mind that all calcineurin inhibitors have these side effects. And this chart on the right here is just a graphical representation of tacrolimus target trough levels and relative risk of graft loss relative to cyclosporin A. And what you can see is at whatever trough level is being targeted, these little balls are below the number 1 line, which suggests that tacrolimus just does better than cyclosporin at every target dosing level. Now, I've talked about a couple problems with these calcineurin inhibitors so far, but there is another problem. And that's that calcineurin inhibitors are nephrotoxic, which is kind of crazy, right? Like, we're giving this to kidney transplant patients, but they're nephrotoxic, both acutely and chronically. The only problem is that chronically, it's really hard to study the damage that calcineurin inhibitors do to an allograft, because it's sometimes quite difficult to distinguish low-grade chronic immunologic injury from the damage that calcineurin inhibitors are doing to the graft. But this study in the New England Journal tried to quantify this really nicely by taking 119 incident transplant or dialysis patients with type 1 diabetes and renal failure. They all got a kidney panc transplant, and then they followed them with triple immunosuppression for out to 10 years, taking protocol biopsies at intervals. Then they had blind pathologic assessment using standardized transplant criteria called the BAMF classification. And what they showed is that over time, the incidence of acute rejection they found in the graft decreased dramatically. And this point out here is 10 years. But what they did see is the prevalence of injury to the graft from calcineurin inhibitors rose dramatically up to 10 years, where the rate is about 100%. Yes.
Ignorance, but I thought that pancreatic transplant had the highest immunosuppression for it. So do you see these same changes if they're just getting a kidney and not a kidney pack?
So you've touched on something that I think is important with respect to this study. The study was actually designed for something completely different. It was designed to look at the the recurrence of diabetic nephropathy in allografts. The only problem is these patients were so euglycemic for 10 years that they couldn't study it because none of them ever got diabetes again. But that's a good question. And that's one of my issues with this study is we don't know, they didn't include how much calcineurin inhibitors these patients were exposed to. We didn't get trough levels, we didn't get cumulative exposure. So it's quite possible that these patients got higher doses of calcineurin inhibitors over time, and that led to worsening graft injury. But the argument I'm going to make is that even if it's less than 100%, it's still going to be a lot, right? And the reality is that isolated nephrotoxicity from calcineurin inhibitors, they think was only responsible for graft loss for 3 patients over 10 years in 115 or so patients. But if you have damage from calcineurin inhibitors and you get other hits, you get an infection or you get a low-grade rejection, you're more likely to lose your graft. So the argument I'm making is not necessarily that it's like the sole bad guy, but if you've got a graft that's limping along from chronic calcineurin inhibitor exposure and you get another hit, it's possible that you're going to lose your graft. So the summary of this part of my talk is that calcineurin inhibitors were revolutionary for transplant. They markedly improved 1-year graft survival from prior medications. They had lower rates of acute rejection. But on the dark side, chronic nephrotoxicity is probably causing graft loss. And there's a number of metabolic complications, and these patients are renal failure patients who are at risk of metabolic disease. Like heart attacks is what kills these people, and neurologic complications. And as we improve renal transplant management, patients and grafts are surviving for longer. We're seeing a greater burden of the complications of calcineurin inhibitors. And I only say this because it really should prompt us to think about how can we develop regimens that spare calcineurin inhibitors. So now I'm going to talk a little bit about belatacept or CTLA-4 immunoglobulin, which is kind of the most recent development in clinical transplant that allows us to move away from calcineurin inhibitors. And I'm going to say that this isn't for everyone, and it's not been widely adopted. And I want you to keep that in the back of your mind when I'm talking about this. But I think it's an important step in the right direction. So I'm going to go back a little bit to co-stimulation to kind of frame the next bit of the talk. And so, as I said, when you get T-cell allorecognition of at an antigen-presenting cell level or at a graft level, you need co-stimulation to rev up that signal, to press the accelerator on the rejection signal. And the primary signal is going to be CD28 on T cells engaging either CD80 or CD86 on an antigen-presenting cell. There's another family of co-stimulation molecules called CD40 and CD40 ligand that are kind of a feed-forward loop on the CD28, CD80, 60. And that's on the activation side. But we all know from cancer that there's also an inhibitory side, the checkpoint side. And so there's actually a checkpoint that engages with this co-stimulatory signal, which is the engagement of CTLA-4 with CD80, CD86 to prevent the interaction of CD28 and prevent co-stimulation. And in the cancer world, we're all very familiar with this because James P. Allison won the Nobel Prize for showing that if you block the engagement of CD28, or if you block the engagement of CTLA-4 with CD80, 86, you can rev up the immune system and potentiate anti-cancer immunity. And here on the right side of my slide, you can see the results from the Checkmate 214 trial, which is the trial in metastatic renal cell cancer, showing that if you give ipilimumab, which is an anti-CTLA-4 antibody with nivolumab, you actually get improved overall survival. But in transplant, we want to dial down the immune system. So we actually want to block the interaction between CD28 and CD80-86, not potentiate it. And so one group thought that what we can actually do is just take CTLA-4, fuse it to an immunoglobulin, and give it to patients, and that'll block the interaction between CD28 and CD80-86. And that first drug is called abatacept. And there's a lot of exciting data in mice that shows that if you give abatacept or this soluble CTLA-4 fused to a human immunoglobulin, to mice who either get a skin allograft, that is MHC mismatch, or a vascularized cardiac allograft, that is MHC mismatched, you can improve survival. They showed that if you give this in concert with CD40 ligand, with blockade, you can actually get an even better result. So this led to the development of abatacept for clinical use. And the first trials were actually in autoimmune disease. And the data in rheumatoid arthritis was fairly compelling. This is a randomized control or double-blind placebo-controlled trial in patients with rheumatoid arthritis who are failing methotrexate. And it showed that abatacept, given at a higher dose of 10 milligrams per kilogram every month, led to improvement of symptoms. And that's this blue line up here. This led to abatacept being FDA approved in rheumatoid arthritis in 2005. So the question then is, all right, so that's abatacept, that's not belatacept. What's going on here? And the reason abatacept we didn't really get excited about abatacept for transplant is because of results from non-human primate studies, where they took rhesus monkeys, they gave them an HLA mismatched kidney transplant, and they gave them abatacept at a high dose, so 20 milligrams per kilogram, along with or without blocking that other co-stimulatory molecule, CD40 ligand. And they showed that the CTLA-4 immunoglobulin alone, abatacept, wasn't enough to produce lasting graft survival. And you can see here these lines going up. Those are rhesus monkeys that got abatacept that ended up rejecting and having rising serum creatinine. But if you give it along with CD40 ligand, you get lasting graft survival, which is this tail out here. So this kind of sent people back to the drawing board, and they said, all right, why is this not working? And the answer they thought lay in the actual biology of the interactions. And they said, well, CTLA-4, we know, binds to CD80, 86 much more potently than CD28, which is the co-stimulatory molecule, which allows it to get in the way of CD28 signaling. But CTLA-4 binds to one of them much more powerfully, 100 times more powerfully than the other. So CD80 is bound much more strongly and is probably outcompeting CD86 for CTLA-4 engagement. So you're not completely blocking this pathway. So the group at Emory developed a mutant of CTLA-4 immunoglobulin called LEA929Y, which became belatacept, that binds to CD86 4 times more potently than abatacept and 2 times more potently than to CD80. And what they showed, and this is a busy slide, but I want you to focus on this panel that I've outlined in red, is that if you give belatacept along with mycophenolate and prednisone, you get long-term graft survival relative to placebo, even when you remove belatacept. So they gave belatacept initially for up to 75 days, and then they discontinued it, and they get long-term graft survival out to 200 days. So this shows that belatacept does something to the immune system that then allows the graft to be accepted longer term. And these data in non-human primates set the scene for the development of belatacept for clinical use. And 2 randomized control trials really lie at the cornerstone of this clinical use, and that's the trial Benefit and Benefit EXT. Benefit is a randomized study of belatacept at a less intense or a more intense regimen versus cyclosporin in patients receiving a standard criteria or living donor kidney transplant. And Benefit EXT is exactly the same study done in patients who received an extended criteria donor kidney that in theory are probably higher immunologic risk. And what they show, and they had about 200 patients in all of these arms, and they followed them for 3 years. Primary outcomes were composite patient and graft survival, which is what you want, right? We want the graft to survive and we want the patient to survive. Composite renal impairment, incidence of acute rejection. And the secondary outcomes were measured GFR at 12 months, prevalence of chronic allograft nephropathy, so chronic damage to the transplant kidney, and cardiovascular and metabolic complications. Now, there's a lot of data in these 2 trials, but I've tried to summarize it here for you. And what it shows that patient and graft survival were non-inferior to cyclosporin A in both trials. Renal impairment, the composite renal impairment outcome, was favored belatacept in both trials. Acute rejection favored cyclosporin A, which is an interesting thing that I'm going to come back to. The prevalence of chronic allograft nephropathy favored belatacept, which again, we would expect. And cardiovascular metabolic complications favored belatacept. And I've included these two charts here at the bottom to really highlight how much better renal function is in patients on belatacept versus calcineurin inhibitors. This line, black line at the bottom here is cyclosporin, and these two lines up top here on both trials are the belatacept groups. Ultimately, these two trials led to FDA approval for belatacept in 2011. It is limited to patients who have monthly access to infusion centers. And this is a quirk that came out of this trial, patients who are EBV seronegative are at higher risk for post-transplant lymphoproliferative disorder with CTLA-4 immunoglobulin. So we try to shy away from those patients when providing this immunosuppression. And last, they get higher rates and grades of acute rejection that are largely treatable. Since then, there's been a long-term follow-up for these studies out to 5 years. And what they've shown is that if you get patients through the early phases where acute rejection risk is highest, patients on belatacept actually do exceptionally well. They have less rejection, less graft loss, less death, and over time, they have fewer cardiovascular metabolic complications, and graft function, or GFR, is much higher than cyclosporin. So the question is, why don't we just all use belatacept then, right? And I want to get back to this idea of this early acute rejection issue. And so when you have a carefully curated trial with carefully selected, included, and excluded patients, the rate of acute rejection was higher with belatacept. But when you do a real world study and you take all comers, high immunologic risk people who aren't going to kind of behave normally, the rate of acute rejection is actually even higher. It's about 50%. And this is a real world kind of retrospective study out of Emory showing that you get about a 50% rejection rate, and that's this dotted line here, in patients on belatacept relative to patients who are on tacrolimus. And again, this is compared to tacrolimus, not cyclosporin. The rejections are high grade and usually treatable. So the question is, what biology is underlying acute rejection in patients on Bela? And there's a number of different things we think are at play here. So first of all, T regulatory cells are an important class of T cells that tamp down on the immune system and facilitate graft acceptance. And we think that blocking CTLA-4 or blocking CD28, CD86 signaling is actually important for activating or T regulatory cells or T regulatory cell survival. So fewer T regulatory cells, increased Th17 cells, which are a special class of T helper cells that are pro-inflammatory that we think are implicated in graft loss by blocking CD28, CD86 interaction. And last, if patients already have a preformed memory T cell response to the graft, which we can't actually quantify clinically now, these memory T cells don't require co-stimulation to start activating and attacking, or don't require as much co-stimulation. So they're probably evading co-stimulation blockade. So the group at Emory said, all right, well, if acute rejection is the main problem, what if we start people on tacrolimus for a little while and then wean the tacrolimus off just to try to get them through this acute phase? And again, this study is from the same study I showed you, that chart with the 50% acute rejection rate. And what they did was they took 205 patients who were on a tacrolimus-based regimen, and they took about 500 patients on a belatacept-based regimen, either where they get 3 months of tacrolimus early on and then wean it off, or 9 months of tacrolimus early on and then wean it off completely. The endpoints they looked at were renal function, death or graft loss, donor-specific antibodies, and then survival from eGFR less than 30, so a limping along graft loss, or death. And what they showed is actually kind of remarkable, is that if you give 3 months of tacrolimus early on with belatacept, and then you wean it off, you do get more acute rejection than the tacrolimus group, but it is lower than 50%, so we've already seen an improvement. And if you look at patients who got tacrolimus for 9 months, the belatacept group actually does better initially, but then then has the same acute rejection rate as tacrolimus. So the strategy of giving belatacept with time-limited tacrolimus allows for sparing calcineurin with a similar graft rejection rate, which is really interesting. Now, this paper has an issue, and when you look at this composite endpoint of long-term graft survival and renal function, If you look at the intention to treat population, there's no difference between the two. But if you look at if you do a per protocol analysis, there is a difference. But it might be difficult to see here, but the number at risk in the belatacept group really falls off here. And I don't know why, and the paper doesn't explain it. So it's hard for me to glean any information from this endpoint. One other interesting feature that they showed in this paper is that patients on belatacept, for whatever reason, don't develop donor-specific antibodies. And donor-specific antibodies, what they are a signal of an evolving humoral immune response against the graft that leads to antibody-mediated rejection. There's no treatment for antibody-mediated rejection, so once you got it, you're in trouble. So this is actually a really interesting facet of belatacept because it tells us that while there may be more acute rejection early on, belatacept does something to block the evolution of a humoral immune response, which is a very scary thing. So to summarize this part of my talk, belatacept is interesting because it has better long-term renal function, less chronic allograft nephropathy, less donor-specific antibodies, and less metabolic disease. There are a number of problems with belatacept that have hampered its widespread adoption, which is that it's expensive. The PTLD issue means that it's not applicable to everyone. You get early acute rejection that I put an asterisk on because you can treat that with time-limited tacrolimus. There's been questions of shortages. Bristol Myers Squibb hasn't been that great about necessarily wanting to produce this. And so there's been an ongoing dialogue about the production of this drug. Requires an infusion center. And the only head-to-head trials have been done in patients who are on cyclosporin. But that being said, so belatacept's imperfect. It might probably work for some patients, but it really should prompt us to look at other signaling pathways. And so I'm going to talk about one more co-stimulation blockade pathway that I think is really interesting and exciting before wrapping up, and that's the CD40 ligand. And we know that this has a role to play in CD28, CD86 interaction, but it also has a number of functions on its own. So before I launch into a little bit of data on this, I'm going to give a little primer on CD40 ligand biology, which is that CD40 ligand is expressed on activated T cells and platelets. CD40 is expressed on antigen-presenting cells, B cells, monocytes, macrophages, endothelial cells, and smooth muscle cells. And in dendritic cells, for example, it's really important for the maturation of dendritic cells and the antigen presentation machinery, the induction of co-stimulatory molecules, so pressing the feed-forward loop on the CD28, CD86, or 8086 interaction. In B cells, it blocks the activation of B cells, production of long-lived plasma cells, and memory B cells that produce antibodies. And in platelets, it causes platelet activation. And the data for CD40, CD46 ligand in non-human primates is actually pretty exciting. And here's an example of a monkey that got an HLA mismatch kidney transplant and was given anti-CD40 ligand antibody. So that's the CD40 ligands expressed on the antigen presenting, or on the T cells. And it showed that even after you discontinue CD40 ligand antibody, and this is where I've drawn this hash line here, you get long-term graft survival out to 500 days. And so this is a greater than 300-day graft survival with no immunosuppression. When you give conventional immunosuppression, ironically, it actually abolishes this effect and you get worse graft survival. So there's some CD40 ligand interaction is doing something to promote a tolerogenic milieu for the kidney allograft in this non-human primate model. So obviously this is very exciting. Two companies developed an antibody to this, Biogen and IDEC Pharmaceuticals, and they started trials in autoimmune diseases. The only problem is these trials showed pretty bad thrombotic complications. And subsequent, people went back to these non-human primate studies and said, oh, geez, these non-human primates were getting horrific thrombotic complications as well. And the reason they think this is happening is because of the activity of CD40 ligand on platelets. And so there's two prevailing theories as to why this happened. One was that the platelets are expressing CD40 ligand and the antibody was binding it directly and activating the platelets. And the other thought was that platelets actually contain granules that contain CD40 ligand that get released, they get bound by an antibody, and this antibody that's bound the soluble CD40 ligand activates the FC receptor on platelets. And now that's the prevailing theory as to why these thrombotic complications have happened. So a number of FC-modified anti-CD40 ligand antibodies are being developed. And I think that that's going to be the next major place we see trials in. There's a lot of exciting data coming out there. The one last thing I want to talk about a little bit before finishing up is the important role that CD40 ligand is playing in xenotransplant. I know that everyone's familiar with the pig heart that was transplanted into a guy back in 2022 at University of Maryland. They used the Revivicor 10 gene edited pig. I talked about that last year. So the immunosuppression protocol that they used in this patient actually contained an antibody against CD40. Their induction protocol with methylprednisolone, ATG, rituximab, complement inhibitor, and anti-CD4 monoclonal antibody. And maintenance was actually with an anti-CD4 monoclonal antibody, not with a calcineurin inhibitor. And the reason they did this was because they wanted to replicate protocols that were successful in non-human primate models of xenotransplant, both in kidney and in heart. And I haven't included these here because we're running out of time. So that's kind of the one hint that I want to give you, that that co-stimulation blockade is going to play a role in a number of different spaces. So that's it for my talk. But I want to finish by saying that hopefully I've convinced you that calcineurin inhibitors were really important. We're not going to get away from them anytime soon. But we need to, I think that they do damage to grafts long-term, and we need to think about how to get away from them. I think that belatacept is a first step in the right direction. It's not perfect. It's probably good for some patients. Some patients are going to do really well on belatacept. But we need to figure out how to identify those patients, risk stratify them, and then identify other targets that might augment belatacept immunosuppressive effect, or augment its ability to initiate long-term graft survival, or develop new targets that can stand alone on their own. And so whether you think that tolerance is going to be the next big thing, or xenotransplant, or precision medicine, I think that we need to keep an eye on co-stimulation blockade and keep pushing the field forward in co-stimulation blockade, because that's, I think, going to be part of any of these different regimens that lie at the future of transplant. The last thought I want to leave you with is that this pathway is extremely complicated. Co-stimulatory molecules aren't just expressed on T cells and antigen-presenting cells. They're expressed on a number of different immune cells. They have a number of different functions. I only talked really about 2 of them, but you can see here there's a smorgasbord of other ones that there is preclinical research data on. And we need to really kind of have ongoing laboratory work in this space to better understand the underlying biology so that we can translate these findings into clinical practice. And that's it. Thank you for your attention. It's been great.